All right, let's talk about our type 1 allergic reactions. These are known as atopy and anaphylaxis. Now, when we think of an allergen versus hypersensitivity, it's important we define these terms. An allergy is just an exaggerated immune response. A hypersensitivity is going to have a delayed reaction. So, allergies, generally speaking, can exaggerate the immune response, most typically with an inflammation event. And with a hypersensitivity, we're going to have some kind of delayed reaction. Generally speaking, we're going to need to have an initial exposure, and then there'll be a subsequent exposure that we have the hypersensitivity to. Now, when we look at an allergen is any innocuous substance. An innocuous is a term that's not very used very often anymore, but it used to be used all the time in common English. Innocuous refers to an innocent, common, um, unnoticeable, or some substance that you would normally not have attention drawn to it, that will induce an allergy in a sensitive individual. Then we have atopy. That's going to be a chronic local allergy. Chronic local referring to either a region geographically, generally speaking, or it can also be referred to a part of the body. When we think of our chronic local allergies, we think of something like hay fever or asthma. And then we have anaphylaxis. Anaphylaxis is not going to be local, like an atopy is, where it's going to be one region of the body. When we have it, anaphylaxis is going to be systemic, system-wide. And this is typically going to involve multiple body systems, typically airway obstruction and circulatory collapse. It's typically how anaphylaxis kills you all. Oh, man, that's not really cool. That's really kind of a downer. And when we look at how many people are affected by these nasty allergies or this atopy and or anaphylaxis, it's between 1/10 and 1/3 of the overall population that's prone to an atopic allergy. There are self-treatment options that you can use for over-the-counter medications like antihistamines or Benadryl. I know for me personally, I'm allergic to poison ivy, so oh darn it, when I go on a camping trip and I wander off the trail, I usually end up with contact dermatitis. That is an atopy. It's a localized immune response. Now, when we look at these type 1 allergies, they're generally speaking relatively mild. When I say relatively mild, it typically means that they're going to be uncomfortable, but they don't typically kill you. Some may potentially be life-threatening. Asthma or anaphylaxis may require hospitalization and cause death, but when we think of something like poison ivy or hay fever, those are things that, generally speaking, just make you really uncomfortable. Or if you're lactose intolerant and you eat some wonderful cheese curds, that would also, or some dairy, that would be another uncomfortable or an uncomfortable and non-life-threatening example of a type 1 allergy. Now, some of these allergies can last for a lifetime, and some are going to be outgrown, and you can no longer have that allergy. Others develop later on in life. Now, when we think of who's going to be affected by these allergies, there's going to be generalized susceptibilities to the allergens that we can inherit. So generally speaking, if your parents are lactose intolerant, there's a pretty good chance that you're going to be lactose intolerant, or you're going to be allergic to some other stuff. Now, if both of your parents do not have any allergies, there's a really good chance that you won't have any allergies. Or if you and your spouse or your partner don't have any allergies, then there's a really good chance that your children, your offspring, your sires or spawn won't have any allergies. Now, we think of the genetic basis of atopy, and remember, atopy is a regional allergy. It's going to be localized to one part of the body. It's generally going to be associated with an increase in Ig, immunoglobulin E production, and we're going to have increased reactivity of mast cells and increased susceptibility of target tissues to the allergenic mediators. Recall, mast cells release a very special chemical. That chemical that they release is histamine. And when we think of increased susceptibility of target tissues to allergenic mediators, think of a tissue being extra sensitive to histamine. Now, when we think of a child developing an atopic allergy, if it's going to be relatively high at 25% if the parents are affected, and 50% if siblings or grandparents are affected. Why on earth is there a higher chance of someone being affected with an allergy if the grandparents are affected, but not the parents directly? I'm not really sure. The genetic basis for that is a little bit perplexing to me. So let's talk about the hygiene hypothesis. This is a pretty widely believed hypothesis that our overly hygienic environment is resulting in our immune systems not being properly trained to interact with the microbes in the environment as they develop. And this hypothesis is very strongly supported by a wonderful study done in Britain. And in Britain, there's the National Institute of Health, where everyone has access to the same nationalized healthcare system, regardless of income, regardless of where you live. And this means that there's just a wonderful central database you can do data mining for. And they found that individuals that in Britain, or England, I should say, or Great Britain, Wales, like that. Anyways, that's a big long side discussion. I'm not very familiar with the distinctions between Great Britain and England. I digress. And individuals from that country where you drink a lot of tea and eat a lot of crumpets, generally speaking, if they are raised in a rural, dirty environment, they spend a lot of time in a barn, they have lower rates of type 1 allergies. And if they grew up in an urban environment, they have higher rates of type 1 allergies. And it's been found that if you have been delivered by cesarean section, so when you come into this world, if you aren't exposed to all of the wonderful bugs that are growing in your mother's vaginal tract, that will increase your risk of allergy later on in life. Or if you are delivered by cesarean section and your mother has a history of allergies, that's going to raise your risk of developing allergies by a factor of 8, or 8 times, 800%, increasing your risk of allergies. Oof, that's a lot. Let's talk about breastfeeding. When newborns are breastfed for the first 4 months of their lives, they have a lower risk of developing asthma and eczema. Now, when we think of breastfeeding, think of how your mother or the mother is eating all these different foods, and all those different foods are broken down and dumped into the bloodstream. So there's going to be slightly different molecules in the bloodstream, resulting in slightly different varieties of milk. And those slightly different molecules making it into the mother's milk will help to expose that growing child to different antigens and help to prime their immune system. We've also found that cytokines and growth factors in human milk are going to cause the child's gut mucosa to help induce additional tolerance to this wider variety of antigens that the child is being exposed to. We've looked at the Human Microbiome Project. We've had a couple discussion board postings at this point on the Human Microbiome Project, and we found that there are 600 species of bacteria that go from mom to baby via the breast milk. And it's not exclusively via the breast milk. There's also going to be a lot of bacteria species that are living on the mother's nipple, around mother's areola, or on the infant's mouth that are going to be transferred through this process as well. Now, how the antigens get into our body is going to influence the effect these allergens have on our bodies. Now, when we think of a protein, I think of a large molecule made of many different amino acids. These are typically going to be complex molecules, and these are highly allergenic molecules. They're going to be more allergenic than carbohydrates, fats, or nucleic acids because of the inherent complexity of a protein compared to these other simple macromolecules. Then we have a hapten. This may be a review for you at this point, but just to review, because practice makes perfect, recall a hapten is a small molecule that by itself does not induce an allergic response. But if it finds a larger molecule, it can induce an allergic response. For instance, if you have penicillin or an antibiotic, these are classic examples of haptens. An antibiotic molecule by itself, a penicillin molecule all by itself, doesn't necessarily induce the immune response. But if you take that antibiotic molecule, that penicillin molecule, and it sticks to a protein, the protein plus the hapten, the protein plus the antibiotic, can induce an immune response. So haptens are smaller molecules that have a molecular weight of less than 1,000 AMUs. And they combine to a larger molecule to become allergenic. Typically, these are going to be both organic and inorganic molecules. So great, that's pretty much everything out there. And you can find them in a wide variety of different areas of our lives. Now, when we look at the mucosa of our gut and respiratory tract, our mucosa is a thin, moist surface, and this surface is very penetrable. When we've talked about the immune system, we've talked about how we have mucosa-associated lymphatic tissue, we have some MALT, we have some GALT, and then we have Pryor's patches, and we have a whole bunch of antibodies in our mucous membranes. But the fact of the matter is that our mucous membranes are still very susceptible to having allergens and pathogens entering into our bodies. Our skin is less susceptible to allergens. Now, the dry, tough keratin layer is, generally speaking, going to serve as a better barrier than the mucous membranes of our bodies, but we still have little tiny cuts and breaks in our skins, and our hair follicles can still serve as access points. So we can still be exposed to an allergen through our skin. It's just more difficult to be exposed compared to being exposed through our mucosa. Now, on the other hand, if we have an inhalant, injectant, or contactant, these allergens are going to have very different ways of being exposed to our bodies. Inhalants typically make it into our respiratory tract, and this is a very high surface area of our respiratory tract. These inhalants are going to induce a very quick immune reaction. Ingestants typically need to be eaten, and these are going to be food allergies, and because our dietary preferences can be very easily controlled, ingestants either can cause a very strong response or they can be easily regulated to cause no response. Injectants, generally speaking, are going to cause immediate systemic responses because they get into the bloodstream, and from the bloodstream, they're going to be spread to tissues throughout the body. And then contactants are allergens that can be absorbed through the skin. Right now, I know essential oils are kind of a big thing right now. They're growing rapidly within the homeopathic medicine world. And an issue with essential oils is allergic responses. These essential oils are going to contain a cocktail of both organic and inorganic chemical compounds, polar and non-polar solvents. So they are going to be capable of penetrating the skin with an increased rate of diffusion compared to just the typical allergens by themselves. So for those of you that are dabbling with essential oils, it's worth your while to test it on your body before you smear it all over. So when we think of a type 1 allergenic or hypersensitivity, I want you to think of an immediate hypersensitivity. They can be inhaled, they can be injected, they can be ingested, or they can just come into contact with your skin. Now, when we think of how these type 1 allergies occur, these are going to occur via mast cell and basal cell cascades. Our mast cells are going to be in all connective tissues, so our skin, our mucous membranes. And these mast cells are going to be in very high concentrations of the GI and urinary tracts because we have lots of mucous membranes there. And each of our mast cells is going to contain approximately 30 to 100,000 cell receptors that bind IgE. When they bind IgE, they degranulate. When we say degranulate, they release the granules. Recall, a basophil is one of the granule sites. We have the eosinophils, the neutrophils, and the basophils, all the PHILs. The phil leukocytes are granule sites, and they have these little speckles in them. And when they degranulate, they release all the chemicals that are stored in their tiny speckles. And in this case, when a basophil degranulates, it releases inflammatory cytokines. The symptoms of this allergy, or this type 1 allergy, generally speaking, are not going to be caused by the direct action of the allergen on the tissue, but instead are going to be caused by this mast cell releasing way too many allergenic mediators, way too many cytokines that affect our target organs. The most notable cytokine is histamine. It's going to be very profuse, and in other words, it's going to be able to diffuse quickly throughout the body. It's very fast-acting. It's going to cause smooth muscle in the small bronchi, not the large bronchi, but the small bronchi to constrict. And when that smooth muscle in the small bronchi of our lungs constricts, that restricts the airways. It's also going to cause smooth muscle constriction of the intestine, leading to constipation. We're also going to have labored breathing and intestinal motility issues. It's also going to relax smooth muscle in our blood vessels. So it constricts smooth muscles in the small bronchi and in the intestinal tract. It relaxes smooth muscle in the blood vessels, and that causes our blood vessels to dilate. When we have the dilation of our blood vessels, that's going to cause our skin to become flushed and red, and also is going to cause our blood pressure to decrease. And then finally, we are going to stimulate, this histamine is going to stimulate eosinophils to release additional inflammatory cytokines. So this is going to cause an escalation of the symptoms. There is a tipping point here, which is called a cytokine storm, where we enter this really nasty spot where we have a positive feedback loop. The histamine causes there to be more actions from the basophils, cause the eosinophils to react. The eosinophils then cause the basophils to react, and it's a nasty positive feedback loop. You never want to have a cytokine storm. Those are life-threatening. Thankfully, they're also the exception. Let's talk about bradykinin. Bradykinin is a chemical that promotes prolonged smooth muscle contraction within the bronchioles, dilation of the peripheral arterioles, increased capillary permeability, and increased mucus secretion. Wow, this sounds like a great way to have breathing problems. So bradykinin, in many respects, mimics a lot of the effects of histamine. When we look at serotonin, serotonin appears to complement has effects that complements those of histamine and bradykinin. In other words, it has similar effects to histamine and bradykinin when it's circulating in our connective tissue in our bloodstream. Now, serotonin within our nervous tissue serves as a neurotransmitter. It's one of the happy neurotransmitters, but when it's out and about in our body, it has a different effect. Another one is leukotriene. This is going to be the slow reacting substance of anaphylaxis. In other words, this is going to cause a gradual contraction of the smooth muscle. And instead of acting quickly like histamine or bradykinin, it's going to act very slowly over a period of hours. And it's going to cause prolonged bronchospasm. In other words, it's going to cause, how can I say this? Asthma attacks that last for hours, as opposed to minutes. And we're going to increase vascular permeability, which is going to cause more fluid to exit the blood plasma and enter into the interstitial cavity, increasing swelling. We'll have increased mucus production or secretion. And then finally, we'll have the polymorphonuclear leukocyte production upregulated. In other words, our leukocytes that have more than one nucleus or non-simple nuclei. So think of your neutrophils, your eosinophils, and your basophils. They are going to have leukotriene will upregulate production of your granulocytes. Then we also have prostaglandins. This is one of those weird ones. A prostaglandin is a signaling molecule based on two fatty acid tails bound together. Prostaglandins are typically going to be associated with smooth muscle contraction. Prostaglandins were initially isolated from male semen and found to cause contraction of the smooth muscle of the uterus, causing the cervix to dilate and allowing sperm entry into the female reproductive tract. So whenever you hear talk about prostaglandins, typically will talk about uterine contractions during delivery. Also, here's a rather interesting story I got from the labor and birthing coach when my wife was pregnant with her first child. If a woman is at risk of premature birth, she should not have intercourse or sex during the third trimester because the prostaglandins present in the male semen will preferentially stimulate uterine contractions and may initiate early labor and delivery. I digress. Prostaglandins may also initiate vasodilation. When we think of vasodilation, I want you to think of the smooth muscle of the blood vessels relaxing and the blood vessels becoming wider in diameter. We're also going to have increased vascular permeability, so liquid will be able to exit the bloodstream. We're going to be more sensitive to pain. Anybody who has gone through labor and delivery will probably say amen to that. And we'll also have more bronchoconstriction. So in addition to relaxing our blood vessels, the smooth muscle of the blood vessel will constrict the smooth muscle of small bronchioles. To counteract the effect of prostaglandins, we should take a non-steroidal anti-inflammatory drug. This will prevent the production of the prostaglandin, not necessarily the reaction of the prostaglandin. Non-steroidal anti-inflammatory drugs, generally speaking, are going to be COX-1 and or COX-2 inhibitors that prevent the production of the prostaglandin. So the obvious question some of you are probably wondering about right now is, well, hey, can I have intercourse during my wife's third trimester if she's taking some NSAIDs? And the answer is no, because you're still going to be initiating or exposing her to the prostaglandins made in your own body. Now, maybe if the male and the female were both taking prostaglandins for a couple days, NSAIDs for a couple days before intercourse, that would be a different story. But I'm not a healthcare provider, so talk to your doctor. So let's talk about sensitization and subsequent exposures to antigens. Type 1 hypersensitivities, you need the sensitizing reaction. You need the initial exposure. And that initial exposure to that molecule, that allergen, is going to cause a B cell to recognize the allergen with the help of a T helper cell. And those two are then going to upregulate the production of plasma cells that make IgE. Recall, plasma cells come from B cells. B cells, when activated, turn to plasma cells and memory cells. A plasma cell just makes a ton of antibodies. As that plasma cell pumps out a ton of IgE, the IgE is then going to bind to a mast cell. And when that binds to the mast cell, over time, with subsequent exposures, since you have an upregulated production of IgE, you're going to have increased exposure of the mast cells to IgE, and then you're going to have the allergic response, and you'll have lots and lots of mast cells releasing their granules and their cytokines into the bloodstream, initiating that hypersensitivity. Here we go. So let's talk about what that causes to our tissues. This is all review, but sometimes it's nicer to review with a picture. It causes vasodilation of the blood, vasoconstriction of the bronchioles. It's going to increase sensitivity to our peripheral nervous system, particularly those associated with pain, our nociceptors. We're going to increase the production of histamine, serotonin, and bradykinin, which is going to cause localized swelling. It's going to increase peristalsis of the intestine, initiating diarrhea and vomiting. We're also going to have, so I guess I stand corrected. I was under the impression that they would cause constipation. My bad. They cause increased peristalsis, not decreased peristalsis. We're also going to have increased mucus production, and we're also going to initiate an asthma attack for many individuals. If we look at IgE and mast cell mediated allergic conditions, these are going to be atopic diseases. They are going to be localized diseases, not affect the entire body. Generally speaking, these diseases are not lethal. Hay fever is a common one. It's a generic term for allergic rhinitis. Or in other words, you're going to just have some generic inflammation of the respiratory tract due to some kind of allergen. Generally speaking, it's going to be mold or pollen spores. This can be year-round if you are allergic to multiple allergens. If you're only allergic to the pollen or only allergic to the mold, you can typically control your exposure. If somebody has hay fever, they are going to have nasal congestion, respiratory, sneezing and coughing, profuse mucus secretions, and mild bronchoconstriction. They're just going to be, generally speaking, really uncomfortable. And then if this is a little bit more pronounced, it could be asthma. Asthma is going to be a respiratory disease that's characterized by episodes of severe bronchoconstriction to the point that it's very difficult to breathe. The airway of somebody who has asthma is very sensitive to very small amounts of allergens. And generally speaking, they're going to have chronically inflamed airways. If they have an asthma attack, they're going to have very labored breathing, and if it progresses, their airways are going to constrict to the point that they begin to suffocate to death. There is a special term for this noise that someone makes when they're having an asthma attack, and that is called rales. And it's a clicking or bubbling or rattling sound. Sometimes it's referred to the wheezing or gurgling noise that somebody makes, the death rattle. Lungs can be very overreactive to leukotrienes and serotonin when somebody has asthma, and that will help to cause that asthma attack. We also find that natural killer cells are going to be recruited and activated and sent to the airways when somebody has asthma, and these natural killer cells are going to only serve to enhance the asthmatic response. We can also have atopic dermatitis eczema. In other words, swelly, inflamed, itchy skin that's going to be localized on the body. Now, this is going to occur through sensitization to the allergen can occur many different ways. They can eat it, they can breathe it in, or they can come in physical contact with it. Generally speaking, atopic dermatitis is going to begin, or contact dermatitis or eczema is going to begin when the child is very young, in infancy, and is going to be characterized by red, weeping, and crusting lesions anywhere on their body. These, generally speaking, are really uncomfortable, and as these heal over, they progress to a dry, scaly region with thickened skin. And these lesions are very itchy, they're very painful, and because they're weeping, they're going to be a very easy access point for other pathogens to get into our body. So there's going to be a lot of secondary bacterial infections associated with individuals that have atopic dermatitis or eczema. We can also have food allergies. Food allergies, by far, are the most common kinds of allergies that affect human beings. Now, when we look at these food allergies, these are going to be associated with food, peanuts, fish, cow's milk, eggs, shellfish, and soybeans. Now, these kinds of food allergies, as you would assume, are going to be mediated via ingestion. You need to get the stuff into your intestinal tract. You need to eat it. Now, if you have a food allergy, there could be vomiting, there could be diarrhea, abdominal pain. There's a wide variety of symptoms associated with food allergies. You could have hives, rhinitis, asthma. Occasionally, And these are the one. This is the example you always hear about. You always hear about the anaphylaxis, but anaphylaxis is the exception. When most people have their food allergy, they're just really, really uncomfortable because they have the hives, the asthma, or the diarrhea and vomiting. Hypersensitivity to these food products occurs when IgE will bind to the mast cells and initiate degranulation of the mast cells. Yet not all reactions involve this mechanism. There are some secondary mechanisms involved. Care should be taken, particularly if an individual is allergic to eggs and you're vaccinating them with an egg-based vaccine or a vaccine that contains the albumin protein. Individuals can also have drug allergies. These drug allergies are typically not going to be allergic in and of themselves. These drugs are going to be haptens, but this hapten can bind to a protein or other macromolecule and become allergenic in itself. Drug allergies is one of the most common side effects of treatment with a drug, affecting approximately 1/20th to 1/10 of hospitalized patients. Common drug allergies include sulfa drugs, penicillins, aspirin, opiates, and contrast dyes used in X-rays. And it's not necessarily just penicillin, it's any of the psyllin antibiotics. If the allergen is intact, not the intact drug itself, but a hapten given off when the liver processes the drug, that in and of itself makes it very difficult to regulate and predict what will be haptogenic, what will initiate a drug allergy. Because as the liver is processing and metabolizing the drugs, the drug is going to be altered by our bodies, and it's hard to predict how our body will alter the drug. We also can have anaphylaxis. This is the one that you absolutely want to avoid. If somebody has anaphylaxis, there's going to be an overpowering IgE-mediated response. In other words, somebody is going to have an out-of-control allergic response. There can be cutaneous anaphylaxis. When somebody has a cutaneous anaphylaxis, hi, Timmy. I'm making a lecture recording. There's going to be inflammation around the local injection site. All right, where was I? Let's see here, systemic anaphylaxis. So if somebody has systemic anaphylaxis, there's going to be the effects of this allergen will suddenly affect the respiratory tract, the circulatory tract, and it can, generally speaking, be fatal within a very few number of minutes. And fatality is typically going to be due to airway blockage. Common causes of anaphylactic shock include bee stings and injections of antibiotics and serum. And generally speaking, these cause anaphylactic shock because they're injected into the bloodstream and are going to be widely distributed throughout the body. These will result in sudden release of chemicals into tissues of the blood. These cytokines are then going to act rapidly on their target organs. So how can we diagnose an allergy? There's the in vitro, and then there's also the in vivo method. Now, the in vitro method is a little bit more expensive, but it's a little bit nicer for the patients. Now, we can use a RAS test. This is a radioallergosorbent test. It's going to measure the amount of IgE present in the body that binds to specific antigens. You can also use the tryptase test. This is going to measure the amount of the enzyme tryptase. This is an enzyme that will be released by mast cells that increases in concentrations during allergic responses. We also perform differential blood cell count, and if there's an elevated amount of eosinophils or basophils, that can initiate or indicate an allergic response. If there's just elevated eosinophils without the basophils, that usually indicates a parasitic infection from a multicellular parasite or a protozoal infection. Now, if we have perform the leukocyte histamine release test, we can take a little bit of histamine from the patient's basophils and measure how much of that histamine is going to be released when the patient is exposed to a specific allergen. So this involves harvesting their basophils and then exposing the basophils to the allergen to measure histamine concentrations. We also have an in vivo method. So let's just pause for a moment here. When we look at in vitro, this is Latin for in glass. So these are going to be, generally speaking, when we talk about in vitro, we're going to talk about in test tubes or not in a living organism. When we talk about in vivo, this is going to be within the living organism in life. Think of like Viva Las Vegas, or like love singing Elvis songs. In vivo is Latin for in life. And if you have in silica, that is Latin for in computer chips. This is a computer simulation. Not that individuals had computers back when people spoke Latin. I digress. So if we have a skin testing, that's an in vivo method where we take the patient and we just inject them little tiny amounts of the allergen. And then we wait a little bit and see what happens. If the diameter of the wheal that forms is measured, and it can be rated between 0 and 4. 0 is going to be itty bitty, and then 4 is huge. There'll be a swelling of greater than 15 millimeters in diameter. So here's a classic example of your type 1, excuse me, of your in vivo method, where you take a patient and you inject them with allergens, and then you wait 20 minutes and look at the response. Now, to prevent or treat a patient that has allergies, you can just avoid the allergen. I mean, if cats make you sneeze like crazy, avoid cats. If you start vomiting whenever you eat peanuts, avoid peanuts. So you can just avoid the allergen. Or you can take a drug that blocks the action of the lymphocyte mast cell and or those chemical mediators. This is where an antihistamine comes into play. It binds to histamine molecules and removes them from circulation. Or we could use injections that short circuit the allergic reaction. For example, we can inject somebody with a corticosteroid. A corticosteroid is a chemical that does many different things, one of which is inhibiting the activity of a lymphocyte and reducing the production of IgE. And if we have less IgE, then we're going to have less responses from the mast cells when the mast cell is going to have the allergen plus IgE binding on the surface of the mast cell. Sometimes we can also block the degranulation of the mast cells or reduce the levels of inflammatory cytokines. Or we can block the synthesis of leukotriene. So there are many different metabolic, physiological targets we can use to prevent the allergic response. One particular drug known as omalizumab, who am I kidding? I can't pronounce that. Omalizumab, also known as Zolar, is a drug that focuses on the monoclonal antibody that is a monoclonal antibody that's injected into the patient. So it's one specific kind of an antibody that specifically inactivates or binds to IgE molecules. There's antihistamines. This is a very common anti-allergy medication that prevents symptoms of atopic allergies. It binds to histamine receptors on the target organs and makes the histamine is effectively non-viable. We also have aspirin and or acetaminophen. Aspirin is pretty self-explanatory. Acetaminophen is also known as Tylenol. And these molecules or these chemicals are going to reduce prostaglandin production to reduce the pain response. We can also look at theophylline. Theophylline is a bronchodilator that causes somebody to have their smooth muscle of their bronchioles relax, thus reversing the spasms that occur in the smooth muscle during these allergic responses. Or we can inject a patient with epinephrine, aka adrenaline. And epinephrine is going to reverse the constriction of the airway. This is a chemical that initiates the fight or flight response. So it will cause more air to get into the lungs, and it's also going to slow the release of the allergic mediators because those chemicals are going to inhibit the fight or flight response. We can also give someone an allergy quote-unquote vaccine. And it's not necessarily a vaccine, but it's really more of a desensitization to a particular chemical or a hyposensitization. So there's a therapeutic way to prevent reactions. And I know my older brother went through this, and he had to get tons of shots through this process. Generally speaking, these are going to be preparations that include pure or preserved isolated allergens. And then they will focus on injecting these preparations into the patients. Now, why this works, we're not really sure. But here's the process. You would take somebody who's allergic to, let's say, peanuts, and you inject them with a little tiny bit of peanut extract. And then you wait a little bit of time, and then you inject them with a little tiny bit more, and you wait a little bit longer, and you inject them with a little bit more, so on and so forth. So it's going to involve a long series of shots over weeks to months. So why does this work? We're not necessarily sure. Here are two big hypotheses. One is that it blocks antibodies. If we inject individuals with small amounts of the allergens, we'll stimulate the formation of allergen specific IgE antibodies that can neutralize the allergen before the allergen binds to the IgE. So the IgG, immunoglobulin G, will bind to and neutralize the allergen before the allergen can bind to immunoglobulin E, triggering the allergic response. It's also hypothesized that if the allergen is delivered in this fashion, it can bind with the IgE itself, potentially, taking the IgE out of circulation before IgE settles on the surface of the mast and or basophil, mast cell or basophil. We also could use a decoy allergy vaccine. And when we say decoy, we're going to look at injecting somebody with a molecule that resembles a bacterium. And this is this allergy shot that contains a molecule that resembles a bacterium is going to engage components of our immune system that are active in the allergy, and it's going to cause them to start focusing on the bacterium or the decoy as opposed to the specific allergen. This has been found to work very well for individuals that suffer from cat allergies, and other versions of this allergy vaccine are in the works right now against that to prevent allergies and protect against viral infection at the same time, which would be really cool if you're somebody who needed to get a flu shot and you suffer from hay fever. Why not get it all done at once? So to review, during type 1 allergic responses, we'll have the allergen exposed to the plasma cell. The plasma cell will then produce immunoglobulin E. Immunoglobulin E then settles on the surface of a mast cell, and when the allergen binds to immunoglobulin E on the surface of a mast cell, it will degranulate. And what was that, Timmy? Okay, you go poo-poo and pee-pee. And yeah, I'm recording with my kids in the house right now. Sorry, guys. Hey, I'm getting it recorded. And let's see here, where was I? So then the degranulation occurs, and then there will be the cytokines released. Your antihistamines or your cytokines released. And to block those cytokines or to block the allergic response, we need an anti-cytokine, so an antihistamine, an aspirin, a theophylline, to counteract the effects of those cytokines on the target tissues and target cells. So, hey, concept check. Which of the following is not an IgE and or mast cell mediated allergic reaction? We have asthma, food allergy, systemic lupus, erythematosus, allergy to penicillin, or eczema. So go ahead and pause the video right now and get me an answer. 3, 2, 1. The correct answer is C. Systemic lupus erythematosus is not an IgE or mast cell mediated allergic condition. So C is the correct answer. And that's all we have for this recording. If you have any questions for me about this material, please feel free to post them in the class discussion board or to shoot me an email. Happy studies!